But next up, we have Dr. Cormac Maher. He's going to talk a little bit about some work he's done with Chiari in pregnancy. So, are we ready?
Yeah, thanks, Caitlin. Can you hear me okay?
Yes.
Yes.
Okay, great. So thank you to the meeting organizers, in particular Caitlin, Dorothy, and Mary for putting this together and trying to salvage a Chiari meeting in the middle of all this COVID stuff. So today I thought I'd talk about a recent paper that we put together on Chiari malformation and pregnancy. Next slide, please. So I have no conflicts of interest with this. I would like to acknowledge Drew Wilkinson, who's one of our residents who did a lot of work on this particular project. He just graduated from our program and actually just a couple of months ago started a new faculty position at Penn State. So Chiari and pregnancy has been an interest of mine, I think, for several years. You get a lot of questions if you have a Chiari practice from obstetricians and from pregnant mothers with Chiari wanting to know what should be different about their obstetrical management with respect to their Chiari malformation. Should that change anything? And next slide, please. And I think, you know, the general posture that you get from the obstetrics community, at least in our areas, is I think depicted by Monk's scream painting here, where there is this tendency for everybody to be very concerned about what the Chiari will mean for the pregnancy. Next slide, please. And I have to confess, with basically no evidence, I was always relatively relaxed on the issue. I see a lot of Chiari patients, and I don't see a lot of Chiari pregnancy complications. So I would advise people just to follow best obstetrical recommendations in general. But I did find myself without a lot of evidence to support that. And so what I'm going to do about today is an attempt to find some evidence. Next slide, please. When you look at the literature on this topic, what you mostly find is a lot of case reports. And here's two examples here. I know the print is small, but the take-home message is there's lots of case reports, and they basically all say the same thing. They say, we took care of a woman with Chiari malformation who delivered a baby, and the mother and the baby are both doing fine. And this is, at least in bad journals, considered reportable and interesting. Again, I think for those of us that take care of a lot of Chiari patients, you'll agree that it's not that interesting and that we see this all the time. But it does reflect, I think, a level of concern, at least in the obstetrical literature. Next slide, please. There are a few small case series in the literature. Here's one from John Oro out in Colorado. 7 patients with Chiari that were pregnant. 4 of these patients had an epidural anesthetic. There were no troubles with any of these pregnancies. Again, considered reportable, even though the case series is small. Next slide, please. Here's a slightly larger case series of 12 patients from the Mayo Clinic. 6 with epidural anesthetic, 1 had a spinal anesthetic, and again, there were no significant problems. 1 patient needed a blood patch after the spinal anesthetic. But again, despite the fact that this is a very small series, it's considered remarkable in that so little is really known in the obstetrical literature about this. Next slide, please. So here's a new article, just came out this year, again in a not so great journal, and the article was called Determinants of Chiari I Progression in Pregnancy. And this was sort of had a hopeful ring to it, and I thought, okay, well, this is great. What did they find? And it turns out that they didn't find anything. It's just essentially a review article reviewing all of these case reports that I gave you a sampling of earlier. Despite not providing any new information, they do have this relatively detailed proposal for how to manage these patients, including if there's any Chiari symptoms at all, to recommend for a cesarean section, to recommend against neuroaxis anesthesia, that is epidural or spinal anesthetics. There are a number of articles out there in the literature like this that don't present data and nevertheless do recommend C-section epidural anesthetic. This paper even went farther still and recommended in some cases prophylactic Chiari decompression during pregnancy for symptomatic cases, which I thought was a remarkable and, in my opinion, not evidence-based recommendation. Next slide, please. So again, a lot of opinions, not a lot of facts. Next slide. Next slide, Caitlin, thank you. So what we decided to do was use the Optum database to study in a large national sample patients with Chiari and with pregnancy to see if there was any basis for concern in this population. We've done a number of studies now using the Optum database. It is an administrative database, and it has some of the limitations that all administrative databases share. That is to say, because you're not using your own hospital data, so there is some limitation of the amount of available information. Optum's pretty robust, though. It is significantly better than other administrative databases, like, for instance, the National Inpatient Sample, in that it's not limited to inpatient stays, it's not limited to single stays. You can actually study longitudinally a patient over a longer period of time for as long as they're in that data set across multiple hospitalizations, multiple diagnoses, and so on. Because it's sponsored by insurance companies, it has a lot of cost and utilization data. Essentially anything that ever costs money or is associated with a code is in this data set. The other nice thing about Optum is it's a huge data set. In any given year, when they were just starting out, they had between 16 and 20 million patients in this data set. And then towards the end, sometimes they're north of 30 million unique patients in this data set every year. One of the significant limitations of Optum compared to National Inpatient Sample is that these are only privately insured patients in this data set. Again, it's an insurance sample. So I think if you're looking at certain types of data like socioeconomic data, that's something important to keep in mind. But I think for our study, it was the best data set that we could use. Next slide, please. So here essentially is our methodology for looking at this. We use the Optum data set. In total, we studied 58.8 million patients, all in the United States, all privately insured. During the time of the study, there were 35,000 Chiari diagnoses approximately in this data set. We excluded Chiari II. We're only looking at Chiari I. There were slightly over 1,000 deliveries in this data set, some before the Chiari diagnosis and some after the Chiari diagnosis. Next slide, please. And here's some of the data that we found. This is obviously a table taken from the Red Journal. This was published a month or two ago. If anybody is interested in more detail, they can refer to that article. One way that we looked at the data is to see if having the Chiari diagnosis made any material difference to how patients were managed during their obstetrical care. And we got at that by looking at when the diagnosis of Chiari was made. Was it made after the delivery or before the delivery? And in fact, there was a difference. If the Chiari diagnosis was known prior to delivery, you were more likely to have a C-section. If it was known prior to delivery, you were less likely to have an epidural anesthetic. Both of those were significant findings. Next slide, please. In addition, the deliveries to women with Chiari malformation are increasing every year as a trend over the 10 years of our study, which you can see very obviously here. There's some statistical noise, but the trend is definitely increasing. Next slide, please. This reflects, I think, next slide, Caitlin, thank you. This reflects just an overall trend with increasing diagnosis of Chiari. This was a different paper that was published in JNS Peds by our group a couple of years ago. Again, if there's an increasing diagnosis of Chiari, you'd expect there to be an increasing rate of deliveries to patients with Chiari. Next slide, please. From that same article in JNS, a few years ago, this is new Chiari diagnosis over time, and you can see that the rate has gone up about 2.5 times over our study period. And this is not cumulative. These are every year, individual year diagnoses. So 2.5 times more diagnosis in the last year of our study than in the first year of our study. Next slide, please. When we look at the overall Chiari group, and the rate of C-sections on an annual basis to see if there were any trends over time, we did find a significant trend. Again, the odds ratio for having a C-section with Chiari is 1.42. So there's approximately 1.5 times as many, or just 1.5 times as likely to have a C-section with Chiari than without a Chiari. That trend seemed to be changing over time. Next slide, please. It was kind of mixed at the beginning. As you can see, there's statistical noise. The two bars are overlapping. Next slide, please. But during the second half of our study, you can see that the lines are really separating. There was no year where C-section was less likely in the Chiari group than in the non-Chiari group, and again, separating over time. Next slide, please. So I think it's safe to say there seems to be more concern about this in the obstetrics community now than there was before, and that patients are more likely to have C-sections now than they were before. The same story is really true for neuroaxial analgesia or epidurals. You can see that early in our study, there's some statistical noise. There's even an overlap here of the two bars. Next slide, please. But towards the end of our study, there's no more overlap, and you can see the Chiari patients are definitely less likely to have an epidural anesthetic than those without a Chiari. And again, this was statistically significant, and there was an odds ratio of 0.6 for that finding. Next slide, please. So you can see that having the diagnosis of Chiari impacts the obstetrical care of patients with Chiari. It changes the recommendations for their obstetrical care. Is there a basis for this? Is there a reason that obstetricians should be making these recommendations? So to try to answer that, what we decided to do was look at So to answer that, we decided to look at the morbidity, the obstetrical morbidity of women with Chiari I malformation, and that's on this table here. Fortunately for us, the American College of Obstetrics and Gynecology has a relatively standardized way of listing maternal morbidity during childbirth. And we decided to use the exact same matrices that they use. So you can see here on the left column, types of severe morbidity during childbirth or delivery: acute renal failure, liver failure, respiratory failure, and so on down the list. Length of stay greater than 2 days is also counted. Discharge anywhere other than home is also counted. Next slide, please. And there's a lot of things that we tracked here. The bottom line, though, is any severe morbidity was found in 10 out of our 1,048 patients. So that's 1%, obviously. Is that an important number? Well, next slide, please. It turns out that it's about what you would expect in any similarly sized group of women having a baby. Again, we found a 1% morbidity in the Chiari group. We decided to compare that to 11,000 women using the same Optum database that did not have a Chiari malformation, and we found a morbidity rate in that normal control group of 1.3%, not statistically different. So based on that, based on our own internal control, we can say that the Chiari group did not have increased morbidity. Using our own data and then comparing it to other large series of women delivering babies to see if our internal control was valid, we can see that, in fact, it appears to be. In the work of Callahan and others, they found a maternal morbidity rate of all women of 129 per 10,000. And again, in our series, we found a morbidity rate of 95 per 10,000. So essentially lower. I think that's a coincidence that it was lower, but the point is we can say, I think safely, that it's not higher. Next slide, please. So to conclude, we found that women with Chiari malformation were significantly more likely to have a cesarean section, were significantly less likely to have an epidural anesthetic. I believe that this is because of recommendations that are being made to them from their obstetricians because of the Chiari. These trends seem to be increasing over time during our study period. I would suggest to you that, at least based on our data, there seems to be very low rates of maternal morbidity with Chiari, not significantly higher than the general population. And therefore, there is no evidentiary basis for making recommendations for care for these women other than best obstetrical practices for other women in their general category. Next slide, please. So again, for most Chiari patients, like the one I've depicted here on the left, I think that it's okay to be relatively permissive, to tell the obstetricians they should follow best obstetrical practices and not treat this patient differently simply because they carry a Chiari diagnosis. Next slide, please. I do want to end though with a word of caution. This patient here with a more severe Chiari, a very significant cervical serings, there simply are not enough patients like this in our series to be able to draw any definite conclusions on whether this particular picture would carry additional risk. So I think there has to be that caveat that these conclusions are valid for most women with a Chiari diagnosis, but I think there must still be rare exceptional cases where more caution is warranted. Next slide, please. So that's all I have for you today. I really appreciate the invitation to present, and I'll take any questions if there's time. Thank you.